reperfusion arrhythmias. Okay, we have here examples of reperfusion arrhythmias, and this is 4 hours after. Not all people will respond, will create, will show reperfusion arrhythmias in 4 hours. Some go earlier, some go later, and some maybe never. But that doesn't mean that we did not reperfuse the patient. Okay, so in this case, reperfusion arrhythmias are actually benign, and they are actually caused by enhanced automaticity, and they are not reentry. Okay, we have a sinus body in here, and you see that we have a short run monomorphic VTAC coming from one focus, a little pause, and then we have a different kind of VTAC in here from a different focus. The patient is tolerating this. Okay, next. We have here a sinus body. We have here a short run monomorphic VTAC. Okay, the next one, longer. We have here a longer monomorphic VTAC. Okay, no, so these three, the patient is okay. Asymptomatic, no sign and symptom for this one. The patient is tolerating these rhythms. The next one, we have here a slow VTAC or accelerated idioventricular rhythm coming from a different focus. The same, the patient is okay. The next one here, we have a sinus body with a longer monomorphic VTAC, the same. It's coming from one focus. The patient is okay. Asymptomatic. Okay, the next one, we have a slow VTAC from different focus. The patient asymptomatic. Okay, here we go. We have narrow complexes here, and it's long. Okay, you see, we have here a QRS of the patient. This is sinus QRS in here. Okay, we have 3 ventricular beats, and we have 2 fusion beats. That is a hybrid. 2 stimuli. Okay, there are 2 things that happen here. Ventricle, the ventricular, and the sinus, they stimulate both the ventricle. We have a fusion beat here. But you see this long run in here, which is narrow complexes. If you make this, you speed up this one. So this is a slow, you speed it up. The T and the P wave together, but I couldn't see any P wave. I'll just say this is SVT. Okay, that is one reperfusion that came out. Okay, the patient is tolerating it. The next one here, we have a longer slow run VTAC. Okay, this is a slow VTAC. The other name for slow VTAC is accelerated idioventricular rhythm. So that is a slow one, and it's coming from one focus. Okay, the succeeding one here, which is the last, I got more, but I just show you until here. We have our slower, accelerated idioventricular rhythm or slow VTAC. Some say the rate is 60 to 110. Some say the rate is 40 to 110. Okay, and the patient so far tolerated all these reperfusion arrhythmias. And as I said, it is enhanced automaticity, and it's benign. But if you have a patient that will become symptomatic with this, then that has to be addressed to the cardiologist. Okay? So if the patient is developing symptoms, then you have to mention to the doc. But usually the patient has already beta blocker. The beta blocker is for automaticity. If you think that there's more symptom, whatever, then they might possibly start the patient on amiodarone. Okay. Probably no bolus, just amiodarone infusion briefly, and that's it. Okay. So, but not all, if ever there is 1 or 2 patients that develop symptoms, that's a different story. Well, as nurses, there are many things that you can do, okay? We don't want any aggravation of other, arrhythmias that could not be reperfusion. It could possibly happen that we have arrhythmias that are not reperfusion, okay? So we have something to assess, be sure that, the patient's electrolytes are corrected, their potassium are okay, and if their potassium is low, you could probably call the lab or enter another thing in the computer and say you want add-on. If the blood sample is still fresh, you could do add-on for magnesium. And the nurse will continue assessing the patient. Be sure that the patient is not in failure. The lungs are clear. You're not in failure. If your lungs are clear, okay, your lungs are clear. And then watch for chest pain. If the patient is complaining of chest pain, possibly the patient is restinosing or what? Because the strip doesn't show you everything. It will just show you lymph leads and 1 chest lead. That's not enough. You have to ask for 12 ECG. And if there's none, that's possibly pericarditis. Okay? And then, so the lungs are clear. We're not in failure. Chest pain, be sure that it's not ischemic pain or restinosing pain or it's just pericarditis pain. We want to know. And then blood works are to be checked and everything. So you're on the lookout of all these things. That's part of our vigilant monitoring to the patient. Okay, so why are we very particular when it comes to a patient going to the cath lab right away or being fixed right away? Okay, if your patient has a heart attack, they're starting, we don't want to end up, this heart attack going to the deeper, layer or to the deeper muscle. If we can contain it to a smaller portion and go to the hospital, we will be saving this heart, this left ventricle, because this is your main pump. Okay, so less death because of the infarction, the better. So we still have a very good pump. Okay, now if you delay, so if you see this part is being dead, sometimes you see cues. Okay, if you delay, then this infarction will progress deeper. So it will hit this part in here, and this part is vulnerable. So 50-50, either it will die or it will live. It lies on your hands. Okay, you see this ST elevation, they are actually potentially will die if nothing has been done. They are injury. Okay, so we have to save this portion, and then that's the reason why we have to bring them to the cath lab, and whatever blocked artery, they're gonna open up the blocked artery. Okay, so we're going to save this part here. That part here is manifesting here, ST elevation. The infarct here is actually the cues. Those are actually the infarct part. These could be still safe. So we have to act quickly for that. Okay, then if ever a patient does not know that he's having a big heart attack, he think like, oh, it could be just gastric upset or anything, or it could be the hospital is too far. This is what's gonna happen. The infarction will spread from innermost outward in everything, and entire heart muscle will be affected. So the full muscle is affected. On that part, affected by the blocked artery. Okay, and that's dangerous because, you know, we rely on anterior is the main part that is doing the pump. Okay, so the response of the patient, you know, either small or big or anything, they can go cardiogenic shock. Okay, they can go possibly cardiogenic shock, or they can just go cardiac arrest. Okay, the effect is after procedure. So we actually dealt with this one early management, good pump, lesser complication. With this one, the patient's still alive, but he will sustain more complications. Example, he can possibly have left ventricular aneurysm, he can have left ventricular rupture, he can have papillary muscle rupture, and chordae tendineae. These structures are the ones supporting the valves. Or they could have mitral rigors, because the innermost part of the layer, that's where all the valves are located, the papillary muscles and the chordae tendineae and everything. So earlier management, better, you know, better recovery and lesser complication. Later management, because the patient's too far maybe, or he doesn't know, then we have more complication to happen. Okay, there we go. So hopefully it will add up to your, you know, information, and we will be putting more STEMIs so that we can have with ECGs. Okay, and again, thank you so much.